All right, welcome to Instructor Newson's testing tidbit. This is just a brief overview on what you have already heard in class and what you're probably reading and studying at this moment. Just to kind of just make sure that you're heading in the right place with your thought processes. Um, Starting with the highs and lows of electrolytes. As we talked about in class, we talked about how if there's not enough electrolytes in the body, that you will see certain clinical manifestations. And if there's too much of something in the body, you're going to see certain clinical manifestations. Here on our screen, we have a few electrolytes. Some of your more popular, your potassium, salt, magnesium, and calcium. But don't forget your chloride and your phosphorus as well. Biggest things I want you to hit on are just knowing your normal value ranges for each of these electrolytes. How they might become diminished or how they might become increased in the body. For instance, with calcium, we talked about the parathyroid. If there's injury to that, obviously we might see some fluctuation with the calcium. We talked about magnesium, actually hypomagnesium with our alcoholic. For instance, with alcoholic, they tend to miss out on a lot of nutrients and electrolytes that are needed for the body because of certain things that they drink that of course do not have any nutritional value in it. We talked about with alcoholics, there's something called a banana bag that's pretty much their fluid filled with electrolytes and nutrients that they have been missing. So we attempt to rehydrate them not only with fluids but also with those key ingredients of electrolytes and nutrients that their body definitely needs to continue to function. We talked about salt as well, i.e. sodium, and we talked about that in regards to fluid and electrolyte imbalances, and specifically with dehydration and fluid overload. We did have a brief discussion about that. I mentioned in my clinical practice, I tend to see higher sodium with those that are dehydrated and lower sodium with those who have a fluid overload. My example for that in class was the gentleman who drank bottle after bottle of water and then came in with a very low sodium level, well into the one teens. And I've also taken care of patients who were extremely dehydrated who ended up with like a sodium level of around 150, 158. Obviously, we know the damages that that can cause on our body. The way that I can think about it with dehydration, how you're kind of correlating the high sodium with dehydration, you got to think about what salt does. It has a very high influence with water in your body, and the more salt in your body, the more water that's going to get pulled out of that. Of the cells. So you got to think of things shrinking as well. And the more salt, the more someone is going to be in that dehydrated state. And in regards to the individual who was drinking a lot of water, you got to think he was totally diluting his body. So he's diluting his system, becoming fluid overload in the system. And that dilution caused a low serum level of his sodium. Now, we all know potassium. Again, we talked about potassium in class. I'm pretty sure you kind of hit on potassium in clinical sites as well. We know that that has the cardiac factor of it, whether it's too high or too low, that could cause some issues with our heart. How can we lose potassium? Let's think about it. Diarrhea, vomiting. Those are some ways that we can lose those electrolytes. So think about how we can also obtain more potassium than we ever needed. The main patient population that we talked about in class was the kidney failure patients. Got to think about those patients. Kidneys are how we excrete urine. If they are having scanty urine or algeria because of their inability of the kidneys to actually operate, then you're going to have that increased waste. And that waste is also considered to have those electrolytes in there as well. So kidney failure patients definitely have electrolyte imbalances that we have to be concerned about, as well as fluid imbalances. When they go into dialysis, we tend to want to take off fluid as well as those wastes that the body cannot rid themselves of now because of the kidney function. So just think about it again. Think about the highs and the lows of the electrolytes. If there's too much, what's going to happen if it's too little? Think about some conditions that might cause too much or too little. And also think about your ad pi. So how would you assess someone with hypokalemia? So that means low potassium. So how would you assess that patient? What type of clinical manifestations will you see? And going on from there, how would you diagnose that patient as a nursing diagnosis? What are you seeing that needs to be fixed, and how can a nurse fix those things? So again, the difference between a medical diagnosis and a nursing diagnosis, we don't necessarily even need a physician's order to treat. There are some things that we do need physicians, or like let's say if we had a nursing diagnosis of acute pain or diarrhea, then obviously we need a physician's order for certain medications. But we can also treat acute pain with distraction, maybe a massage, cold therapy with the ice bag. So we can do some things as well, but just think about how we will be able to help out our patient in whatever current state that they're in. In regards to planning, what are you planning on doing for this patient who has hypokalemia? Obviously, we talked about supplementation, so we might want to give them IV piggyback potassium. Doctor might order PO potassium, or we might be able to use some type of diet with bananas or other high potassium foods. So you're planning on doing some things in order to increase the potassium level. So obviously we're going to end up doing them, which is your interventions. So what interventions did we choose to do? If we chose to do the supplementation of potassium, whether pill or IV, then okay, evaluation time, we need to make sure that that's actually working. So what we can do is ask the doctor for a repeat of potassium level, and we want to see an increase in that. And if they are symptomatic in any type of way, we want to see a decrease in those symptoms. If your evaluation seems to be something that's not being fixed at that time, then we need to go back to square one and maybe go back to the planning phase. We tried this, but we have several other options we can try. So let's try something else. Let's intervene and let's evaluate that. All right, so the highs and lows of fluid balances. You can see someone that's drinking entirely too much water, and you can also see this lonely drop that says stop dehydration. Some of the biggest things you just need to kind of know about this as well is the assessment piece of it. What does a individual look like that has a fluid overload? Clearly, again, we're going to look at maybe edema, listening to long sounds that now have maybe some crackles in it that can indicate some type of fluid. A patient who has ascites, clearly that could be an obvious sign of fluid overload. Ascites, again, has to do with the liver, and there's usually nothing but fluid in there. So just kind of think about what your patient might look like, present with if they are in fluid overload, and what we're going to do to possibly stop it. We talked about the fluid restriction for a patient who has low sodium due to fluid overload. They don't like fluid restrictions, but you got to set it because you're trying to get that body back to a more homeostatic state. So you may only deliver 1,000 milliliters per day for that patient so that we can start getting them back to their normal state or their state before they became fluid overload. Obviously, there's some patients who will always have to deal with certain things, like those who might have congestive heart failure. So let's talk about some medications about it. Some of the obvious meds you will give are diuretics. So just to go back to your classes of diabetics, your potassium sparing, your loop diuretics, and what are some possible complications of giving certain medicines or some side effects of giving certain medicines. Diuretics, again, if it's not potassium sparing, obviously it's not sparing potassium, and we're going to start losing it. So we might put the patient back to square one if they had several different issues. Dehydration, again, Looking at clinical manifestations. What does your patient look like? Dry skin, dry hair, dry nails, brittle nails, dry mucous membranes. Just think about how that patient might present. And geriatric population is a usual population that you do have to worry about dehydration with. Electrolytes may also be off as well because you can kind of see how the sodium is connecting with fluid imbalances, because we can now talk about electrolytes or lack thereof if someone has fluid overload or dehydration. So don't forget to look at your electrolytes when you have a dehydrated patient. That might very well tell you a few things. In regards to the kidney and GI week, when we talked about elimination, go back to other labs that might indicate dehydration. The creatinine is a good indicator of a dehydrated patient. Usually you might see it increase just because the patient is dehydrated. So it doesn't necessarily mean that they have a crazy kidney issue going on. It could simply mean that they're dehydrated. And when you start hydrating your patient with IV fluids, and bolusing them with IV fluids, you can actually definitely start seeing that creatinine level going down. And what I kind of learned about the creatinine level is, of course, it could indicate acute kidney injury, but that's what we're also trying to prevent, is that acute kidney injury. So the sooner that we know a patient is dehydrated and we start that intervention of hydrating them with IV fluids and encouraging PO fluids as well, then we might have a great chance of not getting them into acute kidney injury. Because again, goal with acute kidney injury is not to become chronic. So again, you can use AdPi for this as well. What your assessment pieces are going to look like for someone who has too much or too little fluid, and then your diagnoses, your planning phase. Obviously, you're either going to stop fluids or restrict them, and you're going to go ahead and give them fluids because you know that they have that dehydration going on. You're also going to possibly give diuretics as well. And interventions, of course, whatever your intervention, your planning phase was, what's going to be one of the prioritizations that you need to do for a patient who was in either one of these states. And evaluation. Clearly, someone who's in fluid overload, you hear them, their lungs sound like crap. They got edema going on. Clearly, if you're going to give Lasix, you want to make sure that the eyes and nose are matching up so that what's going out, coming in is going out. You want that balance with the eyes and nose as well. And you also want to see that edema going down, and you want to hear their lung sounds getting better. So clearly you can have an evaluation phase of that. Again, if it's not working too well, or you still see some kinks that need to be done for your patient, definitely ask your physician for something else. Also, you can also go back to your planning phase. What else didn't you do in regards to interventions? Try that intervention, evaluate, and let's see what works. So I hope this little brief synopsis kind of helped just kind of continue to get your mind together with things. Look forward to additional tidbits from me in the next few days, just so that we may have some success.